Welcome to Primetime. Primetime at the BU Library is a celebration of the experiences and the accomplishments of Bethel faculty, students, and staff. It is a collaboration project between the Friends of the BU Library, faculty development, and other offices on campus. Most of the presentations are recorded, can be found in the BU Digital Library. Be sure to check the library news and event webpage and the BU calendar for what's coming up on the schedule. Join us on Thursday, December 10th, as we welcome Gerdin scholars Drs. Ann Holland, Joan Tiffany, Associate Professors of Nursing, and McCall Cleve, 2016, along with Kathy Tilton, former Bethel faculty, as they share their research, Student Learning Impact on a Patient-Centered Care Collaboration Clinic module. Today we welcome Dr. Bethany Gerdin, Assistant Professor of Nursing, who will share her research on the impact of end-of-life decisions by families of blood and marrow transplant patients. Let's give Bethany a welcome.
Well, thank you all for, do I need to turn this on? You're on, I'm on, okay. Thank you all for coming. This is obviously something I'm extremely passionate about, so as much as I can talk about it with people, the better, because I think it is something that the themes from this talk are going to be relevant to a lot of you, whether you realize that at this point or not. So as you can see, I have a very lengthy title. You will see that life-sustaining treatments will be abbreviated LST throughout the presentation, and blood and marrow transplant, which is more commonly referred to as bone marrow transplant, will be abbreviated as BMT. This is the result of my dissertation for my PhD at the University of Minnesota, which I just finished this summer. And so I'm excited to share today. So I'm going to start with introducing the problem and situating the problem in the supporting literature, presenting a brief overview of the research method I used, which is phenomenology, interpreting the overall findings of my research, and then discussing the links and contributions to related literature, why findings were similar, how they were different, and what the implications are for practice and nursing. So I first got interested in this topic as a new RN. In 2008, I had been a nurse for a little over a year, and I was taking care of a patient who had a transplant, I'm not sure, maybe a month before the day I was taking care of him. And he was on multiple life-sustaining treatments the day that I was taking care of him. That day, his wife made the decision to withdraw treatment, and we were waiting for their adult children to come to say goodbye before we stopped treatment. And I remember at one point that the wife and I were sitting on either side of the patient and just, sitting there sharing stories, and she looked at me and she said, "Today I know I'm making the best decision, but I'm so afraid of the weeks and months ahead when I know I will doubt myself." And that just really hurt my heart because I didn't know how best to care for her during that. I was really just relying on maybe what I would want to have said to me in that situation, what I could imagine she maybe wanted, but I just did not feel very prepared for how to care for a patient and a family in that situation. And so I started my PhD about a year later, I think, and really started from the beginning with that topic of what is the experience of these families when they're making the decision to withdraw life-sustaining treatment, and how can we better support them during that time. So I started out by looking what was already in the literature about this, specifically looking at the experience of family members who were making the decision to withdraw life-sustaining treatment and what that process was like. And I narrowed it down to adult patients who didn't have things like Alzheimer's or dementia, and so they were previously healthy adults that then had to have a decision made to withdraw support. I found only 8 studies, so a very small set of literature that really was relevant to my topic, and there was no information about the transplant population in that. And from my experience working with that population for several years at this point, I really came to believe that they were a different type of population. Because if you don't know, transplants are offered for patients who have a blood cancer that is either so aggressive that they don't have time to try traditional treatment, or traditional treatments have failed time and time again, and so they have to try this aggressive transplant. Numbers of success are very hard to pin down, but you can say that 30% success is a fairly conservative number. So it's a very low percentage of people. But because of that risk, I really felt that this population is different because they're already deciding to do a life-sustaining treatment in a sense. Furthermore, the decision to withdraw life-sustaining treatments is really stressful for people. A study in 2005 found that people who have made this decision actually end up experiencing post-traumatic stress disorder fairly commonly. Additionally, it's becoming increasingly common. 1 in 5 Americans die using ICU services, and 90% of deaths in the ICU are a result of limiting or withdrawing life-sustaining treatment. Additionally to those problems, I identified several changes in the healthcare environment that are contributing to this problem. And one is that in recent decades, there are more and more advances in life-sustaining treatment, and patients are able to live longer than ever before. Dialysis, which seems fairly common at this point, is relatively new, and patients are able to live much longer than they used to be able to. With the support of ventilators, artificial nutrition and hydration, this is just becoming something that can be prolonged, life can be prolonged longer and longer. Also, there's been a shift from physician paternalism, when physicians used to just say, this is what I think you should do, this is what you should do, to really focusing on patient autonomy, which sounds great, but also puts a lot of extra stress on the surrogate. There are limitations in advanced directives, which is an additional problem for surrogates. There's a whole ton of literature about this, so I won't get into that specifically now, but advanced directives are a great step, but they don't make this process easy for surrogates. In addition, we talked about the extreme stress that surrogates experience during this time. So my specific aim for my study was to interpret the meaning of the experience that family surrogate decision makers ascribe to the decision-making process of withdrawing life-sustaining treatment from an adult and young patient. My inclusion criteria were that I interviewed surrogate decision makers 2 to 12 months after a patient's death. 2 months is long enough, according to the literature, for it to be past the acute phase of grief. And the other studies that are looking at had gone as long as 24 months, but I thought that would introduce too much variability, so I stuck with 2 to 12 months. So I met with them one-on-one and had sent them the question ahead of time so that they had time to think about it. And this was the question: what was your experience during the time surrounding your loved one's death? What were the circumstances that preceded and culminated in the decision to withdraw life-sustaining treatments from your loved one? So my research methodology was interpretive phenomenology as defined by Ben Mannen. Phenomenology focuses on the lived experience of the individual, so it was a perfect methodology for what I wanted to find out. I did my interviews. They were anywhere from 45 minutes to 2.5 hours, and they were then transcribed verbatim. I read them many, 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 many times, and as I did that, themes began to emerge. And so essential themes in this methodology are themes that without them, the experience wouldn't be what it is. And so then I wrote those themes up as a narrative describing this experience. So to describe my participants, my surrogates, I had 10 surrogates. And again, these are people whose family member had died within 2 to 12 months after a transplant. I had 9 Caucasians and 1 Somali patient. Their ages ranged from 30 to 60s. 2 males, 8 females, and about half were spouses of the patient, half were children, and I had 1 sibling. And because we're really looking at what happened to this patient, I have included statistics about my patients as well. I had 8 patients, so you can see that 7 were Caucasian, 1 was Somali. They ranged in age from their 30s to their 70s. 4 males, 4 females, and then the underlying diagnoses are very varied. You can see them there, but all of them are blood cancers. I also had a good variety of the types of transplant they had, and what I think is most interesting to look at on this slide is the length of time from the initial diagnosis of cancer to their death was as short as 4 months to as long as 19 months. And the length of time from their transplant to their death was as short as 2 weeks to as long as 9 months. So a lot of variability there. So this is a model of my themes, and we'll be talking about each of these individually, but this is just kind of a picture to show how they all fit together. And what I tried to demonstrate with this is that that middle circle of knowing the patient as a person should really kind of stand out. It's always the focus of this entire process. Nothing happens without always considering the patient as a person. And while that's always a central focus, surrogates were also working through the information, receiving support through trusting relationships, and then recognizing reality, which made them move down to actually making the decision and living with that decision. So the first theme of knowing the patient as a person, which again, I can't stress enough that this was always the central focus of these people, was they started by considering the advance directive. And because the transplant is such a risky procedure and a lot of patients do get to a point of not being able to make their own decisions, it's really stressed to them that it's super important to complete an advance directive. So all of them did have an advance directive, and the surrogates would start by re-looking at that advance directive and reading what had been written down there. One participant said, the fact that they make you do the living will ahead of time kind of forces you to discuss the options. That's probably one of the biggest things, knowing for a fact that this is what the person wishes. However, that was only the starting point, and it was not the most important thing. The most important thing was actually telling stories and remembering the patient's goals. So, for example, one wife told me that she and her husband completed their his advance directive, and he said that he didn't want her to pull the plug. No matter what, he didn't want her to pull the plug. However, he also said that if he survived, he wanted to be able to recognize who he was, recognize his grandchildren, and be able to interact with his grandchildren. So she ended up making the decision to withdraw support, even though she had this clear memory of him saying, don't pull the plug. She also remembered that he wanted to be able to interact with the ones that he loved and know who he was. And when the physicians weren't able to give a prognosis that guaranteed that, she decided he wouldn't actually want to live this way. And so it gave them, they had the advance directive, but if they had a story or a comment or something that made them believe that they could go against that advance directive, they would do that. So as they were always considering this patient as a person, they were working through the information. And the information that was needed in my study was very different than what I found in related studies, because my patients were generally very familiar with the hospital scene. They had already been in and out of the hospital many times for treatment for their cancer. And so they didn't really need to learn the culture of the hospital. They didn't know how to learn how to get along with physicians or nurses or what the roles were. They really just needed to know what was happening with these complications that they had heard about from a transplant, but now they were experiencing firsthand. And they also needed to know the difference between the regular oncology and transplant units and the ICU and what was different there. And that actually caused quite a bit of stress because they were not always allowed to spend the night in the ICU. They weren't quite as involved as they were able to be on the other units. And so that was difficult for them. They also needed to piece the information together. These patients could have multiple teams following them: the transplant team, infectious disease, pulmonary, renal, the intensivists. All of these people were coming in and telling them their story and what they saw happening and what their suggestions were. And sometimes those stories were very different depending on who was telling them. And so patients really had to work through that, and they did this by what they called navigating a sea of doctors and managing conflicting messages. And so they usually attached themselves to one point person, and it was different for everybody that I talked to. It was just whoever they felt that they connected with personally. It didn't matter what team they were on, it didn't matter how long they had a physician, it was just who they felt they had some sort of personal connection with. And so in that way, they were able to take these conflicting messages and deal with them and kind of come up with one story that they were able to tell themselves and their families. They also needed to receive support through trusting relationships at this time. And this primarily happened when they felt that a healthcare team member was caring for the person and not just a patient. One participant said that they got a chance to get to know her. The nursing staff really got to know her personally. So she wasn't just a diagnosis at that point, she was a person. And her personality was taken into consideration as far as decisions for her care. So when they felt that the healthcare staff was actually trying to get to know the patient, who they were, what they liked, what was important to them, what their personality was like, they really connected with those people and felt support. This happened most often with nurses. because of the time that it took to build relationships. And nurses on this unit were generally having 12-hour shifts 3 days in a row. So they spent the most time with these people. And this allowed them to have discussions and conversations with them during the day that they couldn't have during like the 5 minutes that the physicians came and rounded on the patient, or during the formal family meetings that would be scheduled. They could start a conversation, they could end it when it was too much. They could restart it several hours later, and the nurses were always just there for them to be able to talk about these things with. One surrogate explained that she couldn't have had the conversations during those 5 minutes from the medical team when they came in to present their plan and ask the family if they had questions or if they had made a decision. She said those conversations take time and trust, and she believed that that could only happen with the continuity and time that nursing care provided for them. So at some point, and this could happen really whenever, sometimes it was after 24 hours, sometimes it was after 25 days, they began to recognize reality, and they described this as problems starting to stack up that were causing more harm than good. So for instance, they would fix the patient's liver, but then their kidneys would fail. They would fix the kidneys, and then they started having heart problems. They would fix the heart, and then they started having whatever other problems. And so eventually they decided that we're really doing more harm than good, and we're just prolonging things here. They described it as plugging holes in the dam. They needed to physically see the changes in what the patient was going through. One patient was presented with the decision of whether she wanted to withdraw support or not, and she said, I'm just not ready, let's wait a couple days. And during that couple days, the patient started to develop worsening graft versus host disease of the skin. And so that was the change that she needed to see in order to make that decision, and then she did make that decision. Another person who was with her mom every day for 25 days in the ICU decided that she wanted to withdraw care. And she called her brother to let him know that this is the decision she was going to make. And he was okay with the decision, but he wanted her to wait, not do it that day, wait until after the weekend when there was going to be a family wedding. And she said, at that point, I didn't care about anybody else. I wanted what was right for mom. I had seen my mom that way for 25 days, and I saw the reality of what was happening. Nobody else saw what I saw, and I didn't want to keep making my mom go through that. I saw her every day. Nobody else got to see that. So when they weren't there to actually see what was happening, it was harder for them to agree to make the decision. They also needed to accept the change in prognosis. At this point, they needed a different kind of information. They didn't want to just know if the patient was going to survive. They wanted to know at what quality of life would the patient survive. So they really wanted physicians to be able to tell them that. And one patient said his wife had acute respiratory distress disorder, or ARDS, and they said that she would be able to survive, but she would have a trach, she would have oxygen, she would be in and out of the hospital probably her whole life. And he said to me, she was very outdoorsy, and it was hard to keep her home. She wanted to run and go hunting, she wanted to fish, and I know if she had to carry around an oxygen tank or have limitations, she wouldn't have enjoyed life the way she wanted to. She was a marathon runner. And the physicians were saying that if she would have come out of the ARDS, she'd have either had a trach or oxygen the rest of her life. And she'd have so many issues that she'd be in and out of the hospital throughout the years. I just knew that she would have been mad if she would have woken up and that would have been the case. She would have been mad that she went through that. And so when they were able to see that maybe the patient would survive, but again, they were going back to those conversations and remembering what was most important to the patient, survival wasn't the ultimate goal. It was really quality of life. So the penultimate red flag was when they did recognize that the patient wouldn't recover to a level that was acceptable to them, and this moved them into making the decision. At this point, it was important for them to tell the family. This is a huge area where my study was different than others. Other studies, they really had to have the entire family on board before they'd make that decision. In my study, they didn't. I had 4 out of 10 cases where the family wasn't on board and they decided to make the decision anyway. So that's a huge difference, and we'll talk a little bit about that later. But they wanted to tell the family, and they wanted to have a formal meeting with the physicians present, with healthcare team members present to discuss it, but then they also wanted to have individual time as a family to just talk and share stories about the patient and have kind of a, just kind of a moment to remember and reflect upon who this person was in their life. After the decision was made, they needed to know what to expect. They didn't want the patient to suffer, and across the board, this meant struggling to breathe. So they really needed to know whether the patient would struggle to breathe or not. They wanted individual time to say goodbye, not just with the whole family in the room, but time to just sit and be with the patient by themselves. And this was really awkward for them to try to coordinate with their family and ask them to leave so they could have time. And so this was one area that they thought nurses could have really helped with, was providing that time alone. And once they made the decision, there were kind of two trajectories that they would go down, and they weren't like mutually exclusive, but to talk about them separately makes more sense. So the positive side of this was that they felt trusted to do what was right. And because that patient had chosen them as their surrogate and it had put the trust in them that they would make the right decision, they really felt empowered to be able to make this decision. When patients said that, you have to remember that this is what my wife would have wanted. And if you can respect that, then you're doing your part of it. They put their lives in your hands for a reason. They chose you. And if they give you the confidence and they trust you to do that, then I think you need to fulfill that and do what you need to do. And so they really had the confidence that they were making a decision that was honoring their loved one. However, the negative side of making the decision, and this usually happened actually months after the death, was second guessing the decision to have the transplant itself. And they often wondered whether the patient would have maybe had less time, but more quality time if they had just undergone regular chemo or done hospice. And so there is a lot of doubt and stress about that decision. And the most important thing after the decision was that they were able to honor and remember the patient in a way that was special to them. So they all talked about some way that they remembered and honored the patient. And when it really struck me how important this was when the sister of the patient was telling me that her other sister made these necklaces with the thumbprint of the patient and wanted to give them to the whole family. And she had a little shrine in her apartment with pictures of the patient and stuff. And the surrogate I interviewed wanted nothing to do with that. She didn't want the necklace, she hated the shrine, and she felt so guilty about that because she wasn't grieving the same way her sister was. But she said what was important to her was that she went out and found a bottle of Coke that said, have a Coke with her brother's name on it. And she bought that Coke, and that was really special. And she went out and she bought a book by his favorite author and read the book. And to her, that was her way of honoring and remembering him. And just so it's important, as a takeaway, to let people grieve the way they want to grieve and not pressure them into grieving the same way that you do. So, discussion and implications. So there were some similarities. There were similar communication needs. Everyone really kind of wanted to have one message presented to them, not all these different teams presenting different messages to them. Everyone in the related literature in my study needed trusting relationships between themselves and the healthcare team, and if they didn't have someone they trusted, they would never make the decision to withdraw. They needed to recognize futility before making the decision to withdraw life-sustaining treatment. And remember, futility could just mean, it didn't necessarily mean that the patient was going to die, that they weren't going to survive to a level that was acceptable to them. And they had a decreased burden when they believed that they were doing what the surrogate wanted. And that was similar in the literature, but it was more common in my study that they had that confidence. So some of the differences really surround the advance directive. In related literature, even if patients had an advance directive, they usually had filled it out privately, maybe with their physician, maybe with someone else, but they hadn't talked with their surrogate about what they really wanted. And so the surrogate could look to this advance directive, but they're like, oh shoot, well, what did she mean if this happened? What did she mean if this happened? Whereas in my study, they had those conversations together, lots and lots of conversations together. And so the advance directive wasn't the main thing that they looked to. And because of that, all of those conversations that they had, they felt more authorized to accept the role. Whereas in the related literature, surrogates had more stress because they didn't feel authorized to accept the role. And again, like I mentioned, consideration of family was necessary in the research to get the whole family on board. In my study, it wasn't. And I think that that's because they had that empowerment, that they were doing what the patient really wanted. So implications, the focus on end-of-life conversations and family and stories. not relying solely on an advance directive. So I think I've said that about 20 times, but that's by far the biggest thing I get from that. And that's where it affects everyone, because even if you think you're doing a great job and you have an advance directive completed, that's not helpful. It's not helpful until you sit down with the person that you want to make decisions for you and really tell them what matters and why it matters and what your goals for life are. In the hospital, one provider should be a point of reference. It was so incredibly stressful for these families to have 5 different physicians coming in and telling them different stories. And one would be really pessimistic, one would be really hopeful, and that just increased the stress by leaps and bounds. The role of nurses. So before the decision is made, because nurses have that special opportunity to have the long shifts with the patient and really have that continuity of care, they really need to step up and be willing to accept that, because they were in the role to make the biggest difference. They were in the position to really connect with those families and be a support for them. And whether that was answering questions or just listening to them, or just being a presence that they weren't alone, it looked very different for everyone. But one thing that's important for nurses, especially me teaching new nurses, is that the surrogates didn't need the nurses to know all the answers. So you don't have to be afraid that you don't have the knowledge. You just have to be able to go get the answer for them. So families were totally fine when they said, we would ask the nurse tons of questions, and if she didn't know the answer, she'd go find the answer for us, and that was fine. So I just think that's a huge learning lesson and would have helped me that day that I described when I was a new nurse. They also need to let the surrogates and family take care of the patient in whatever ways they want to. So being able to help wash the patient up, clean their face, put lotion on, help do turns, that was really, really important to family members to be able to have a hands-on experience at that time. And then also making that effort to get to know the patient as a person. And then afterwards, providing for individual time for surrogates to be able to say goodbye, maybe asking, is there anyone who wants to spend some time alone with the patient, and just kind of policing that and helping the surrogate not have to do that themselves. Another thing I thought would be really helpful for these surrogates is to maintain contact with them after the patient's death. A lot of places are really great about having support groups and support and resources there for them during this experience, but what I found is that there's a time about 6 months later that they experience extreme stress and worry about that decision to have the transplant. And so we could maintain contact with these people and keep them connected to resources that would really be helpful. And then expectations for surrogates, to provide realistic expectations, specifically that breathing thing. So they wanted to make sure they knew if the patient would breathe or not, and whether they'd be in pain, and all of this kind of stuff. And there was one person who they told her that her mother's brain was so damaged that she wouldn't take a single breath after they removed the ventilator. So that's what she was expecting. They removed the ventilator and she breathed for 2 minutes. She was so traumatized by that 9 months later, I was the first person she had talked to about that day. She hadn't even told her husband about it because it was so hard for her. And so she even said, if they would have just said that there was a chance she could breathe, that would have been okay. She just wasn't expecting it, didn't get what she expected, and that was extremely stressful for her. So that's it. Are there any questions? Yeah, Ernie?
I know you probably couldn't ask that as part of your study, but did faith, was that a factor at all with any of your patients? Were you able to talk?
I went in with a very open-ended question. I didn't want to lead them into what the factors were. It came up a lot in the literature, so I was expecting it to come up, but it didn't really come up. The closest I can come is they would say things about afterwards, and I actually for this talk didn't include a lot of information that they talked about for after all of this happened, but it was their faith was a source of comfort for them afterwards. But during it never really came up as being a primary thing that they were considering. Dave?
Yeah. Do you think that the use of the pulse, the provider or ordered life-sustaining treatment form would have been easier, or would it had any difference than an advanced directive, which could be quite lengthy and
I don't
cumbersome.
think that for this patient population, the post is appropriate.
Okay.
Because that's for patients who are really at end of life, right? Like you wouldn't be surprised if they passed away within a year.
Right.
This situation is not as cut and dry. I don't think pulse would be good for this patient population. But that's my personal thought. Yeah, I agree.
Interested in hearing more about the maintaining contact with surgery after, like that
Yeah,
aftercare
yeah.
with surgery.
Yeah. So that is a great thing that I maybe will hope to follow up on to do more on. But I mean, just off the top of my head, his question, if you didn't hear, was ideas of how to maintain contact or my thoughts on that after the death. I know that where I work, our social workers send cards on anniversaries. But I almost feel like that's, I don't know how I would feel if there's nothing and then all of a sudden in a year and I get this card from these people, you know what I mean? So I think establishing support groups, because we have a lot of deaths where I work, and I'm sure that's the same for any transplant patient or any transplant center, of forming support groups for people who have had a patient who died would, I feel like, be a pretty simple thing to do, to have that resource for them. Because a lot of them, especially, that one really hadn't talked about it. And it's the same story of like, people ask a lot of questions initially and are really supportive initially, and then it kind of tapers off. And so like me coming in and interviewing them was actually super therapeutic for them because they were able to talk about it and to someone who understood. So I feel like just having people available for them to get together with and talk about their experiences. Do you have a question?
Yeah, help me understand the idea of being a surrogate. Is that something that is formal? Like there's something that's written that says this person is my surrogate and they
Okay.
have the right to make
So-
decisions and have the right to go
Good
over what
question.
appears
Yeah.
in my
If-
advanced directive?
Yeah, if you have an advanced directive, there's a place to put like, this is the person I want to make decisions for me. If that person can't, then we go to this one. So if you have an advanced directive, you can say that. If you don't have an advanced directive, every state has different laws. So in Minnesota, it defaults to your like next of kin, husband, child, whatever. But I know like Wisconsin, is anyone from Wisconsin? I don't know, I was just at the Respect and Choices conference, and it sounds like Wisconsin is very different. So I don't know what other states are like. But it will default to like here, your next of kin, first relationship. Linda?
Yeah, my mother died under these kinds of circumstances, and I just really, the whole thing of talking with that person about, what would you want? I think I was more prepared for my mom's death because I had those conversations with her, and it wasn't so much the advanced directive. She told me she wanted me to make the decisions, but my siblings had not talked about it at all with her. And so they were totally, at the end, they were just so totally not prepared.
Yeah.
And, I just think that's a takeaway from this.
Yeah.
You have to talk with them
Huge.
about what's coming,
Yeah.
and what are your preferences. And, yeah.
And I think like it's the role of the person who might be experiencing, what they want, but it's also like we need to be willing to hear that and be able to be willing to say like, okay, I will sit and talk with this about you, even though it's really uncomfortable.
Yeah.
I have sisters who have totally different views on that, and one will not talk to me about it at all, and one, I'm her decision maker, and we've talked about it a ton. So I think it's really hard to sit and talk, especially if your family member is young and healthy, but you never know what could happen, and so you really need to be willing to talk about it with people who want to.
I'm curious if you saw any differences in the responses with the one Somali individual versus the Caucasian surrogates. Thoughts in, their thoughts, their feelings. Were there any kind of differences you were seeing that you attribute to cultural?
She actually will probably be my next case study because her story is amazing. She's a woman, she's Muslim, she chose to withdraw support against the wishes of his family, which, holy cow, how does that happen? And so I really want to talk to her more about it, and she said I could contact her again if I wanted to know more. She was not what you would expect from a Somali couple. she said things like, you know, his family didn't live in the United States and they all came pouring in during this time and wanted to dictate what was going to happen. And she said, I'm his family, his children are his family, you're not his family. And she said things like, I am Somali, but I'm also American. And so she was really quite a lot more comfortable with being able to make that decision. And she talked about, she had 3 imam come in and the physicians talk to the family. And she kind of scooted out of the room and went and just spent time with the patient by herself. And she said she just laid her head on his chest and just felt him tell her, it's time, let me go. And so again, that just really knowing what he wanted gave her that confidence. But she's not what I expected her story to be. So, yeah.
Was 10 enough?
10 was not enough. You know, you say you keep going until you reach saturation. And I would say I actually did reach saturation, but I didn't have the diversity I wanted. I had the one Somali patient, and so ideally I would have kept going to get more ethnic diversity, but I wanted to graduate. And my committee said it was fine. So, and the other limitation was I didn't have translators, and so my people had to speak English, and so there were people from other ethnicities that fell into my that I could have recruited, but I didn't have translators. So no, that's the one thing that's really a limitation in my study. Just kidding, there's more. Yeah.
Are you going to publish this?
Oh, we're working on it.
Oh, good.
Yeah.
Since there hadn't been many studies, it
No.
doesn't make sense to.
Yeah.
to
Exactly.
How many different, what was the location of this surrogate? Like, how many different hospitals or one location?
One. And despite it being patients being recruited from one center, it is a center that treats patients from all over the world. So I was hoping to get a little more diversity than I did.
You just interviewed the surrogates one time?
One time, yeah.
Okay. Do you think there'd be any change, or like what do you think would come out of a second interview to say, so from our last talk, how have you been feeling, and what's your sort of recovery process in your grief?
I think the best way to do that, because I had people, the shortest I had was right at that 2 mark, and I did 2-month mark, and I did have someone right at the 12-month mark. I think the best way to do that would try to give them 2 months and then 12 months. I didn't really notice differences between my recent and my less recent, but I think if I was intentionally trying to do that, that would be the way to go. Because that would be really interesting.
This question comes significantly from my ignorance in HIPAA stuff, in maneuvering that and what, I guess, how were you able to come in as to deal with them, these things,
Well,
get certain info, and then how much you could share, I guess?
It was actually, my recruitment was really interesting and really annoying because I had to go to like university, hospital, there was a lot of red tape. But the IRB actually, I was really nervous that they would have a problem that I was a nurse working on the unit I was recruiting from. They actually said that that was a very big strength, and they wanted me to put that in my recruitment letters because they felt that they would be more willing and feel better about someone wanting to talk to them if they were an insider and kind of knew their story a little bit more. So it was actually, I think, a strength, and in my recruitment letters it did say like an experienced PMT nurse will be contacting you or whatever. So I was able to access them through my nurse manager. I didn't make the initial contact with them, but my nurse manager was able to.
Had you been the staff nurse for any of the?
One of them.